So now I think that we go directly to anatomy of the lower face by our dearest Professor Sebastian Cotofana.
Yes, that's absolutely correct, my dear Ferial. We're going to move now into the lower face. After we've seen upper and middle face treatment, we're going to move into the lower face. And in the lower face, we're going to do types of treatment. First, we're going to do jawline and perioral and chin. That's going to be the first segment. And then after that, we're going to have even more beautiful injections of the lips. So this is why...
You were on...
What? All good?
Please close the other micros.
Hold on 1 second. 1 second here.
Sorry, we are hearing also something. Close the other micro, please keep open only Professor Cotofana's micro.
As I mentioned, we're going to have 2 lower face sessions. The session number 1 is going to be jawline and chin. So we're creating the frame, and the second session after that is going to be the lips. It's very similar like we're going to have the great Egyptian baking show when we're making a cake. We're starting the foundation, and then at the end, we're putting the cherry on top. And the cherry on top is going to be the lips. So exactly, this is what we're going to do now. So the first one, we're going to focus on the jawline and on the mandibular angle, and there I'm going to show you some risk zones that might be in this area, some tiny little vessels, but I'm not sure if the camera can capture those ones. Let's go with the overhead camera. The respective dissection that I conducted for you is a fairly long dissection, starting from the temple, going all the way down into the lower face. You can see that flap that I'm reflecting here. And now if the camera can zoom down on towards the jawline, I think you can see here, this is the artificial separation of the superficial fat. So what you can see here in this view is actually a beautiful representation of layer 1, the skin, layer 2, the superficial fat, and layer 3, the platysma muscle. You can see here 1, 2, and 3 as they are located in this area. And what's happening now is that below the platysma, there are a lot of structures. Normally, you wouldn't see them because everything is covering, but I will uncover all of these structures for you a little bit, and then we will look into this area. No, we're going to stay in the lower face, please. Zoom out. Yes, thank you. Just zoom out a little bit. Thank you. So now we're going to reflect the platysma and the superficial fat, keeping in mind that when we do superficial treatments, we're in this respective area. Because here you can see there are not a lot of vessels. Actually, there are not many, just small arterial perforators. But now we're going into the deeper plane. And now I'm reflecting here the respective platysma muscle and the SMAS, as you can see here. And now when we're moving to the other camera, I think you can see now here how I'm reflecting the platysma one by one. And as I'm doing that, I can expose exactly the jawline. You can see this here. This is the view where this entire flap is going up with the superficial temporal fascia, with the SMAS, and with the platysma. If you're going now back to camera 1, that will be amazing. We're going to reflect now here this area, and as we zoom in, there's one structure that is always camouflaging the mandibular angle, that's looping around this area. This is this structure here. This sometimes is fairly large in more mature individuals, and this here is the parotid gland. This is a gland that increases in volume as we age. So now I'm reflecting this gland out of the view, and immediately we have a branch of the facial nerve that's located in this area. And this shows us here the masseter muscle. Now the masseter muscle is connected to the bone. There are not a lot of vessels in this respective area here, but there are vessels slightly more anteriorly, and this here is the facial vein. As you can see here, this is the facial vein that's located anterior to the masseter muscle, and slightly more anterior, well, there we have the facial artery. You can see how all of these structures travel. As you can see, they are in contact with the bone, and normally there's a little bit of fat, but this fat does something very important, because this fat prevents that the platysma is connected to the bone. When we have fat here, and we have the vessels as they travel from the neck into the lower face, this fat protects those vessels, but this fat also prohibits that the platysma is connected to the bone. But as soon as moving out of the danger, suddenly then we have a connection to the bone of the platysma. And this connection is called the mandibular ligament. This connection is here, and if we zoom in with the camera, we can see that respective area, how the mandibular ligament connects from the bone to the platysma. So there's really a strong connection here. I think you can see this when I'm pulling it up. It's a very, very strong connection, as you can see here. And all of this is happening in the jaws. This is why we have the jaws of this respective area. Now, I mentioned to you that in this area, especially of the mandibular angle, well, we do have some tiny little vessels. And let me show you these vessels as of now. I'm reflecting sternocleidomastoid muscle, and I'm able to show you the internal jugular vein, which is here. But let's move the vein out of the way. And then we can see a tiny little vessel, which is called the carotid artery. You can see this vessel in this view here. And I think in the other camera angle, you can see here how the common carotid artery is located and how deep this artery is, and actually how massive, how thick this artery is. Common carotid artery, internal, external carotid artery, and you can see all of the different branches as they travel towards the face, including the facial artery, as you can see here. This is here the massive facial artery as it branches off from the external carotid artery. If you're going back to the other camera, there's a very important view that I would like to show you. If I'm putting the vein out of the side, look at all of these vessels here. All of these vessels, how close they are located in relationship to the mandibular angle. Here is the mandibular angle, and if I'm putting the vein out of sight, you can see how this angle here, how it close related to all of the vessels. So in other words, when we're trying to go deep here area, we need to find bone. If you don't find bone, but instead of injecting here, well, there is a lot of stuff going on. So we should be very mindful and careful of this respective area. So now I'm going to reflect back the platysma because I want to show you one more important muscle before we go to the respective ultrasound transmission. Platysma goes back up, and you can see how the platysma covers the entire area as well as does the skin. And in this way, it actually doesn't look like a lot. It just looks very simple, that there's not much going on, but believe me, there is a lot of stuff going on along the jawline and the respective mandibular angle. Now, as we move the donor, I want to show you a quick view of the perioral musculature. And for this, I did a quick dissection. I reflected the skin and the superficial fatty layer. And this exposes now the DAO, the depressor anguli oris muscle. But in addition to this, we also have the presentation of the horizontal labiomental artery, which is here in the superficial plane. And we also have branches of the ascending mental artery, which we here also have in a superficial plane. So when it comes to the chin zone, we can go deep, but we need to be mindful of the respective vessels that come from the neck going upwards, like these small perforators that we have here, like the facial artery. But also in a superficial plane, we need to be very careful because there are also some vessels. This is why we can apply treatments in a superficial area, but when we come to the chin, there is where we need to be deep, and deep below the mentalis muscle, as you can see here, because with this we can influence its function and can improve the chin aesthetics, as you can see here with the respective dissection. So now we're going back to camera 2, and with this I'm coming to an end of my demonstration, and I hope you enjoyed this anatomical overview of the lower face, and with this we're going back to performing the ultrasound. Thank you very much.
Thank you so much. Wonderful, like always, Sebastian, we were enjoyed. So do you have any question, Thomas? Or Mohammed, do you have something for Sebastian, for anatomy?
Yes, Sebastian. In fact, I have a question concerning the retaining ligaments. So there's almost a discussion about do they stretch over time, or are these structures so dense and so strong that it's only they are keeping the soft tissue in place, and the soft tissue is sliding over or besides them, and they keep their length over the years?
So Thomas, I would be in agreement with what you said last. And this is also in line with what a recent publication did. It was an animal study that came from China, And what they did, they looked at different rats, differently aged rats, young, middle-aged, and mature rats, and they looked at the collagenous distribution properties, vascularization of the facial ligament. Besides, they looked at the zygomatic ligament and the zygomatic ligament complex. And they found out the older the animal, the more rigid, the more stiff, and the more strong and solid the facial ligaments were. And one of the major reasons was the explanation that when a ligament was young, and they provided beautiful images in that paper, the collagen fibrils were very loose oriented. They were like all over the place, very thin, not aligned. But in mature individuals, all of these ligaments were suddenly bound together, bundled, formed very strong, thick ropes. And this also resulted in the increase in their rigidity and stiffness. So personally, I think this provided very great support for what you said very correctly. Your second hypothesis that the ligaments stay in the strength, stay strong, and the soft tissues around these stents creating the jolts, as you mentioned.
One more question, now coming to the surgical part. That means because of this and this more or less, like you say, strengthening or shrinking of the ligaments, it makes sense to cut them when you're doing the facelift because you have a better distribution of the soft tissue. Is this right?
Yes, Thomas, that is true. There are, when they are so strongly connected and adherent, of course it makes sense to transect them to get a better redraping of the respective soft tissues. And I think I can show you that also in the camera here, because you can imagine when we're pulling the soft tissues back, like we do this during facelift surgery, of course we get a better transmission when the mandibular ligament is transected or when the zygomatic ligament is transected. You know, we get a much better pull. However, especially in the lower face, sometimes we transect this ligament and we want to have also an influence on the submandibular area because we're just moving everything upwards. The problem with that is only that sometimes we need the stability of this ligament, because then when we transect this ligament, the jolts from this area, we extending them into the anterior area until the area of transection. So in other words, there are pros and cons for the respective transection of the ligament, but for facelift surgery, absolutely, this gives you a better repositioning outcome.
Excellent explanation.
Great,
Thank you very much.
So now we go to the ultrasound?
No,
No? Directly
injection first.
Okay.
The
So
sequence
we go
change.
directly to
I'm
injection.
doing ultrasound after the injection to
Okay,
show
very
the
good.
parotid gland and the bolus.
Perfect.
So now we are, we have our very dear Lakhdar Balhawari from France, as a very big expert, particularly on myomodulation for lower face. Lakhdar, stage is yours.
Thank you, Ferial. So we are with Wael, and we are going to inject the lower face. The lower face is the jawline and also the chin. We show you just before with Wael, where is the masseter? If she crunch, perfect. So I don't draw, but the masseter go like this, like this. What is important to understand? In the angle, you have the masseter, you have the parotid, and you have after the skin. So when you inject deep, I don't draw. When you inject deep in the angle, we are going to be deep in the angle where in the masseter. But if we inject at mid-depth, we are in the parotid. And if we inject superficially, there is no problem. So we are going to inject in the angle, bolus deep, no problem. We can do a second bolus just in the masseter. Why? Because in front of the masseter, as show you Sebastian, we have the facial vein, then the facial artery. And then we are going to inject the chin. The chin, there is two kinds of injection. We can inject superficially with cannula, or you can inject deep in the pogonion or in the mentum. We call this gnatio in French. So we are going to do all this. Remember what we said with Wael. If you draw a line between the lip corner and the tragus, just above you have the transverse artery and the parotid duct. And the muscle is under this line. After is the masseter is a tendon. Okay. So first we are going to inject. Well, I feel the angle. Have a look on the profile view. Have a look on the front view, and have a look if it's symmetric or no. Angle, I feel the angle, and I inject exactly like this. Deep.
Doctor, I have a question.
Yeah?
Because we can see, I don't know, maybe I'm doing a mistake, but is there injected before this lady for the chin or not?
We can inject the chin first because you are.
Okay.
You have injected before?
Yes.
2 years ago? Which product, please? Juvederm, which one?
Okay.
Voluma? Okay. So we are going to use still age.
Okay.
Okay. Deep, small,
No, I didn't.
slow.
No, I
Not more than 0.3. Why?
No,
Because
sometimes,
if you
no,
inject
it's
too
not
much,
no, honestly,
you are going
not
to
doing
have
it.
a diffusion, a spreading on the parotid. So 0.3. Deep, small, slow.
Lakhdar, are you in contact with the bone or what's the feeling?
Yes, I am in the bone. Remember, as told you, Sebastian, the depth of the masseter is 0.2, 0.3, not more at the angle, not more. So you have to be at this level. If you inject too superficially, remember you are in the parotid. Okay, have a look. It's the GW1. I have injected here. But I can do a second bolus. A second bolus is in the masseter at this level. You can aspirate if you want. I inject 0.2. Deep, no risk because the fascial vein is more lateral, more medial, not at the level of the masseter. Even you can have.
Your objective here is the myomodulation on masseter?
Yes, Ferial, yes, because when they have any trouble in the dynamic of the masseter, we can have a very good result in terms of myomodulation for bruxism, etc. So the future, botulinum toxin have not delivered all the secret of the botulinum toxin, but the hyaluronic acid is the same. We are going to discover many things. So this, remember what told you Wael and what told you also Sebastian, never deep in the mesophase. This is the metaphase, this is the mesophase. In the mesophase, you have the fascial vein, as told you Wael just previously, and the fascial artery. Okay, have a look. 0.4, we can inject more. Never inject in this part, in the metaphase, more than 0.5, not more. If you need more, you can inject superficially with cannula, like this, more superficial, but not more than 0.5 at this level. Have a look on this side and have a look on this side. You can see the difference. Okay? Now, I'm going to inject the chin. The chin, I can inject in the pogonion and also in the mentum, in the gnation. Pogonion, no danger, except as we told you before, you can, and as I showed you yesterday, you can have the ascending mental artery, a branch of mental artery. So if you inject the chin in the pogonion, have a look, we inject like this. Aspirate, deep, small, slow. Not on the periosteum, before the periosteum, because if you have artery, you can have, you can see with echo Doppler. 0.3. And this injection is inside the mentalis. So we are going to have myomodulation of the mentalis. And remember, the function of the mentalis is to lift the chin and to project anteriorly the lower lip, as told you just before Sebastian. So have a look. and have a look on the profile view.
It's amazing.
Now, I want just to have a better shape in the menton. Like this. Aspirate. Point 2. It's enough, point 1. Good. Okay. I can add just on the left side, on the right side, in the pogonion, like this. I am in the mentalis. Remember, no danger regarding the nerve, because the mental nerve is lateral. Okay? So now we are going to do the second side. So have a look. Jawline. Only with 0.5, remember, in the angle 0.3 in the masseter, and here 0.2 in the masseter also. Never inject in the mesophase. Why? Because this is dangerous when you inject deep, because the facial vein and the facial artery. If you need some time to inject at this level, you inject more superficially with cannula.
Lakhdar, may I ask you a question? If you see this dimpling of the retaining ligament, what you sometimes see here, how would you approach this one?
The ligament, ligament.
Yes.
You have the masseter ligament here.
No, the mental.
The mental
retaining,
here,
yeah.
at this level, at this level, at this level. Yes, but don't care. Don't you inject where you have to inject, but you have no influence on the ligament, in my opinion.
So I have a question from Thomas here. You know that there is two approaches for this. This
I do
lady,
this
for
and after
me,
I
it
do
is not a very
everything.
good example for the injection of the jawline
Okay.
because
Okay.
already she had a good jawline. But my question is, there is two schools for that.
I
You
finish
know,
and
the
after
people
you do it.
believe that
I
when you
finish.
inject superficially, you need less products and the result is more visible. And some, you know, schools like Jan Trokel for wildlife in US, that he insisted all the time to inject on the bone. And we need a lot of products
I
by
finish
each way.
quickly and after
What is your idea about?
I think it's a simple answer. The answer is the more you want to recontour or reshape something, the deeper you get. Also, you have to think about the future. That was what we were discussing, because we were discussing where does the filler last longer.
it painful?
So the more you get to the periosteum, the longer it lasts. So it's also in terms of how it will look in the future. You have to decide in which level you have to go.
Thank you so much.
Okay, can we follow?
Yeah.
Okay, perfect. So left side, the same. I do it quickly to have time for the echo Doppler. We have put alcohol, angle, deep. I
You
go
do the
through-
same approach like that?
Exactly the same. I go to the skin, I go through the parotid at this level, and I am in the masseter. 0.3.
And you never inject here by cannula?
Yes, you can, of course you can. Yes, of course, you can.
Okay.
You can do it totally. But remember, Ferial, when you inject in the masseter, you are static. When you inject under the skin, you are dynamic. The product can move. But you can't, in my opinion, you have not to inject deep with cannula. But you can do it. But in my opinion, you have not to do.
My dear Lakhdar, do you have something to add? Because if there is exactly the same method, it is better because we are a little late. We can go through the anatomy of the lips by Sebastian.
Wait
progress
just one
the
second, I
session.
finish and I answer.
Sebastian, can you hear me?
Point.
Lakhdar, one last question from my side. As you're doing the myomodulation on the chin, this means you don't use any toxin for the mentalis.
When you need to change the shape of the chin, use hyaluronic acid. If you don't need to change the shape, use botulinum toxin. And
أهلا
just
بيكم.
one thing, what I showed
أول
you,
حاجة هنتكلم
if you have
الفيشيا
myomodulation of the
معناها
mentalis,
فلوس اوف هير ان ايه المفروض اصلا دي مري ان يبقى فيها هير
Can you close the micros of the others?
اور سكار السكارينج بارت
so
برايمري يعني
in this
Sorry.
case, have a look on the lower lip. I did the myomodulation of the mentalis,
ستاندر
so
مع
I have
الليجن زي سكار زي نيب
I have less projection of the lower lip. And if I project posteriorly the lower lip, I have a better support of the
كوبيك
upper lip.
اكزامينيشن عشان نوصل الاول للتشخيص
Excuse me, technical team.
Yes, you can.
Please close all of the
وائل
micros.
احنا قلنا ان
we have
الكوزز المين
overlap between two rooms, I
في منها
think.
برايمر فيشل طبعا اشهر حاجه في
Perfect.
الفيشيا ارياتا والتليجن افلوفيوم 3
الوبيشيا ارياتا.
بعد خدوا كيموثيرابي
That's why I hate technology.
شافت او ترايكوتولومانيا وتراكشن الوبيشيا في ستيج بعد كده لو قلنا في تدخل في السيكاتريشال الوبيشيا
الأخضر, are you with
برايمر
us?
سيكاتريشال
Yeah, I am here.
yes.
Yes, of course.
Okay,
of course.
please continue.
Okay.
Okay, we can continue.
Just to show if we can have the scan of the right side, I just want to show you just quick the parotid gland, the bolus inside the muscle on close to the bone. If we can have the screen, ultrasound the screen. Where is the camera? Ultrasound the screen. Please. Switch the screen to the ultrasound. You can inject. I'll show
No,
you the
it's
picture.
finished.
Yeah. Okay. Can you zoom on this even? Zoom on this. That's fine. Yeah. That's okay. Zoom on the screen. Zoom in. Zoom in, please. Okay. On the left side, I will show you. This is the
طيب
parotid
لازم ناخد
gland.
هيستوري ولازم نعمل
Oh
اكزامينشن
God, it's gone.
No.
نوصل
It's gone.
للتشخيص
It's gone. No. Yeah.
ملخص
Just give
سريع
me a
ازاي لو جات
second.
لنا حاجه
Yeah.
So
Now we
we
have
can-
it.
الفيشيا
we can-
هنعمل ايه؟
Exactly. Now we have it.
شوف
Okay.
الديستريبيوشن بتاع
I'll show
الفيشيا
you.
ده ازاي؟ هل هو لوكلايزد اور باتش؟
This is the left side.
طيب
Is the parotid
لوكلايزد ورا
gland.
ديفيوز
Oh God.
باترن معين هحدد
This is
هي
parotid
سكارينج
gland.
زي ما دكتور حسن
This is masseter muscle.
سكارينج
And I'm gliding anteriorly, and you see
اديني
this
هنت
pocket.
هي
It's close to the bone and kind of inside or below the muscle. You can see it here. Sorry, I try to make it very fast. Thank you.
وغالبا تلج
It's okay.
بتعرف
So I
باي
think that we go now directly to the anatomy of the
criteria في
lips
الدرم.
by Professor Kutofana. Sebastian, are you here?
سيفليتك الوبيش
Of course, I'm here, my dear Ferial.
كان مانيفستيشن اوف سكند
We should,
Yeah.
my
There you
friends,
go, guys.
we should have a,
ولا
I don't know.
So,
Rosy
now,
Galwi-
as I mentioned to you a little bit in the previous
فيه-
introduction,
لازم
when
يبقى
we're
فيه
gonna,
fibrosis
when
في
we're gonna do the lower face, we said we're gonna do
فرقها لي
two
من تراكشن اوف هير لك هلاقي السكين لسه نور
That is not me. That is not my voice.
No, no.
So let's see if we have this interference taken care of. That would be amazing. So,
Sure.
as I mentioned to you in the previous aspect, we had the lower face introduction, which we focused on jawline and chin and the mandible angle. But now we're putting the cherry on the top in the Great Egyptian Baking Show. And the cherry on the top, of course, are the lips. And when it comes to the lips, we need to understand the lips are a symbol of sensuality, of sexuality, of attraction, of femininity. And we need to understand this because the lips are a very special area. They're not like the temple. You know, when you look at the temple, you don't have this like, No, you just have this only for the lips. And in the lips, we need to understand there are a couple of things we need to consider. And I will walk you through these lips, how the aesthetic appeal of the lips is component. Now we zoom in a little bit, please. So what I want you to see is
clinical
here is
سريعاً بعض
exact.
انواع النون سكارينج الوبيشيا دي بتيجي
That is
المامز
still not
دايما
my
بتشد
voice.
شعر الطفل عشان ما بيبقاش فيه اي هير او اي بيبقى فيه فيلا ستير مش
Somebody please go to the hall of
Session
the
in front.
alopecia session.
وده بيفرق فرونتال فايبروزنج هلاقي الفايبروزنج السكن سكارينج
Sebastian, I'm sorry really for this problem.
يا حبيبي يعني سيبريت الترددات بتاعت
السيشن لا
الالوبيشيا ارياتا وبتاع يعني جاست سيبريت التردد بتاع القاعه الثانيه خالص عننا يا واد.
You can see Professor Saudi that he's trying to solve this problem, but technical. I'm sorry, Sebastian.
Yes, sorry Sebastian for this and please continue.
السكن اول ما حالة هير مشهورة جدا في الأطفال
It's okay, no problem. I mean, I would love to continue, but I'm not sure
Yes,
whether
because
it
it's
works.
interrupted.
Yes, I'm really sorry, but I'm ready here. I'm just waiting until the technical issues are solved, and then I can continue with the respective area.
Okay.
But it seems it might be sorted now.
Yeah, I think that is good. Please start. Maybe it's good.
Yes, okay. I will just gonna start. We're gonna switch now to the other camera, and I would like to explain to you something that is very, very important when it comes to the lips. This is something that we very rarely consider, and we also very rarely teach. So when you look at this and this body donor, here this area of the upper lip, this is white or beige in skin. It is white, whereas starting from the vermilion border, it's starting to change in color and it's starting to get red. So in other words, we have a transition between white and red. And the fact that we have red here is an evolutionary advantage compared to other mammals and even compared to monkeys, because the fact that this portion here is red increases the color contrast between white and red. And the increase in color contrast results in attraction. Because if everything is white and beige, this here stands out. So the point of contrast increases the attention. And the second point that we need to consider is the fact that we don't have only change in color, we also have change in volume. And well, I'm not so sure whether it makes sense to continue if we are getting these interruptions. I'm really sorry.
فاروت راسي
Did you find that which session it is?
اجي وتوقف لحد
We should change the micro of this lady because it's out of service.
I mean, I can also change my microphone if that would help.
No, the problem is it is the hall because the lady, when speaking, it is in our hall. So they should close this micro and change to another micro.
That is absolutely correct, yes. The audio to this hall should just be open for this microphone. I would agree, yes.
The proportion of
Mohammed, can you go to the session of, because this is Arabic, I don't know which session, is alopecia, I think.
the step and
No, but they should change the micro. They should close the micro and change it immediately, please.
we
If you want, I can go. So, here is ready. Nice. Before and after. We can appreciate very good, the lifting effect of the injection. Thank you. You're a great injector.
No, guys, we don't have.
So what I want to say, you can use cannula, you can use needle, as you like. If you are comfortable with cannula, you inject. If you are comfortable with cannula, you use it. If you are comfortable with needle, you use it. So you can have fabulous results with cannula and also with needle.
This is yours also. Please explain the jawline injection. This is yours.
Jawline? Oh yeah, jawline. So you can inject with cannula superficially. You can inject deep, but we have to divide the face not horizontally, but vertically. Proface, mesoface, metaface. Metaface is where you have the masseter. Remember, you can inject deep in the masseter, not too much product, because you have the parotid at the angle. So never retrograde injection, never. Only deep,
Do you want to add?
but if you want to inject, if it's not enough, if you want to inject superficially with cannula, you can. If you inject with needle deep in the masseter, not more 0.5, 0.3 in the angle, and 0.2 just more medially. And after, if you need to inject more, you can use cannula to inject superficially. Never in the mesoface because you have facial artery and facial vein. You can inject, never inject deep in the mesoface, but if you need to inject, you inject superficially with cannula.
Thank you. And I ask my dear Sebastian if you add something, if you have some points.
Well, I hope you see that what we do is apply the anatomy in terms of we know where the vessels are, we're injecting away from the respective vessels. So everything can be regarded either you see the anatomy and during the anatomic demonstrations, or you do see the anatomy with ultrasound, which was a very beautiful demonstration when it comes to the different aspects of seeing the anatomy in different colors. Like with me, you saw the anatomy in color. With ultrasound, you saw the anatomy in black and white. At the end of the day, you still need to know it.
Thank you so much, and I think that this very great session is finished.
Very great session.
So we stay on the stage only to have a photo, all of the injectors and moderators, and see you in the very wonderful sessions till the end of the day. Thank you.